Okay, so tennis elbow, lateral epicondylitis, inflammatory condition at the lateral epicondyle of the humerus, is also often a result of repetitive supination of the forearm. It's a site of origin for wrist and digit extensors and forearm supinators. The other options, pronator teres, flexor carpi radialis, have the origin at the medial epicondyle, and the triceps inserts at the olecranon lead to triceps tendonitis. The only option is the extensor carpi radialis brevis for tennis elbow.
And these respond very well to, they don't respond well to NSAIDs, they respond very well to injection and a elbow.
So a lot of people pick salmonella thinking of osteo in patients with sickle cell, not common for septic arthritis. In these patients, staph is still the most common organism for adults, children over the age of 2. And think of gonorrhea for people under 35, sexually active. Pastorella associated with animal bites, mostly osteo, not septic joints, and Pseudomonas associated with infection of the sternoclavicular and sacroiliac joint and IV drug users. We're thinking of the 4 criteria for the Cannabis lines: tenderness along the course of the flexor tendon, fusiform symmetric swelling of the digit, pain with passive extension, finger held in flexion. Most of the time you're going to find some kind of penetrating injury prior to the development of this.
They love to put Connor sign on the board, on the insert. It's there all the time.
So mallet finger is caused by forced flexion of the DIP, leading to rupture of the extensor tendon at the insertion at the base of the distal phalanx, or has a bony avulsion of the tendon insertion site. Usually involves splinting the DIP in full extension. Swan neck deformity is hyperextension of the PIP and flexion at the DIP. The Fourier deformity occurs from forced flexion at the PIP, causing tear at the central portion of the extensor tendon. Patients are unable to fully extend the PIP with the wrist and MCP joints fully extended. And jersey finger, as a result of avulsing the profundus tendon from its bony exertion. Dupuytren contractures is basically fibrous thickening of the palmar fascia, seen in usually men over 40, diabetics, alcoholics.
And you're going to see this. I've seen this a lot in people playing baseball or softball and they get with the ball, and you want to put them, as Miguel said, you want to put them in extension splint. They don't have to be hyperextended, but they at least should be extended, and they need to be in it for like at least 6 weeks.
If you take the splint off, you got to start over.
The next question is kind of vague, it's just limited by the characters. question is referring to juvenile dermatomyositis, inflammatory autoimmune condition, usually seen in girls ages 5 to 10. You'll see the goer sign, using their hands to get up from sitting on the ground. There's a heliotrope rash, it's reddish or violet, coloring of the skin on the eyelids, periorbital area. Also, Guthrun's papules and nail folds at telangiectasias, along with constitutional symptoms. And to uveitis, this is involving less than 5 joints, affects females more than males, usually at ages 2 to 3 years old. The knees and ankles are most commonly affected. You have constitutional symptoms such as fever, they'll be absent. Fever and rash will be absent. Most common complications are uveitis, leg length discrepancies, temporomandibular joint arthritis. The uveitis is seen in about 1/4 of patients. Guttron papules seen in juvenile dermatomyositis, like in the previous question, and hepatosplenomegaly and the negative ANA tests are seen in systemic juvenile arthritis.
You can also see uveitis with other reactive arthritides. So I've seen it, for example, with Crohn's and ulcerative colitis, Lyme disease.
Worried about neck fascia in this patient. Treatment is fluid resuscitation, hemodynamic stabilization, broad spectrum antibiotics, and emergent surgical debridement. So ulnar collateral ligament rupture, referred to previously as a gamekeeper's thumb. It happens to skiers when they fall on an outstretched hand while still holding a ski pole. It happens with acute force abduction of the thumb at the MCP joint. They have a weak pinch and won't be able to resist abduction. The volar fatal pulsion at the PIP is a Orlando fracture. The second choice would be a Bennett fracture. Osteosarcoma is the most common bony tumor in children. Most common sites is distal femur, proximal tibia, proximal humerus. Occurs at metaphysis. X-ray classically shows sunburst pattern or Codman triangle. You see the Ewing sarcoma occurs at the diaphysis, appears as onion skinning of the periop. X-rays, the giant cell tumors, they look like lytic lesions, commonly called soap bubbles. And the osteochondromas are benign pedunculated lesions on the external bony surface. So this would be the staph scalded skin syndrome. Having some exotoxin release, the positive Nikolsky sign. Desquamation occurs usually 3 to 5 days after the onset of rash. Management involves fluid resuscitation and antibiotics. The burn center admission would be for Stephen Johnson's and the TEN. Clinda would be appropriate for toxic shock syndrome. Tinea capitis, and need the systemic antifungal agents because topical agents don't penetrate the hair shaft. You can think of treating with selenium sulfide shampoo or 2% ketoconazole in the first 2 weeks to prevent transmission.
Research fluid is usually used.
Yeah.
And if it doesn't work, you can give them a more fatty diet. This is absorbed with fat. You get a higher concentration that way.
And if you use things like chronically, like greasy fulminant, you should always check their liver function.
Yeah.
Not most likely diagnosis. Most likely, what other findings are most likely to see? So HSP or Iga Vasculitis, affects children between 2 and 11 years old, caused by deposition of the IgA complexes, usually associated with the preceding URI. Classic triad of symptoms of abdominal pain, arthritis, and palpable pruritic rash. GI symptoms such as abdominal pain and GI bleeding are seen in 50 to 75% of cases. For the coronary artery aneurysm, the feared complication of the Kawasaki, and polyarteritis nodosa is associated with the hepatitis B seropositivity.
They can also get into susception as well. And they get nephrotic syndrome is also can occur. Nephritis.
IgA nephropathy.
Yeah.
And MISC now, right?
Yeah.
All these kids now would be, an overlap between MISC.
So stage 3 is a full thickness injury with visible subcutaneous fat. Stage 1 is intact area of non-blanching erythema, lasts for more than 1 hour when you remove the external pressure. Step 2 is partial thickness, the disruption of the dermis. And stage 4 is full thickness with visible muscle, tendon, joint, or bone.